I was on the steps of the Capitol building when the ACA was passed and remember those votes coming in and how excited everyone was because it had been decades since any type of healthcare reform had been passed.
I started in HR.
Actually mimic the hormone that
Northwestern Memorial Hospital here in Chicago.
Really had the chance to speak with physicians from every state in this country.
You save $32 million in an hour.
Hey, I'm Joe. Welcome to the 5 Mile Difference podcast. The name comes from something that's quite close to me, where I grew up in Philadelphia, 2 zip codes just 5 miles apart. The average life expectancy difference is 20 years. We're here to talk about why that's the case and what you and I could do to change it. Today, I am excited to introduce Stephanie Strong, the CEO and founder of Boulder Care, a leading provider of telehealth addiction treatment. They've raised over $85 million to date, helping over 10,000 patients. And I think what's striking to me throughout our conversation, Stephanie, is I think you're quite possibly the kindest person on the planet. So really excited to have you on. And to start off, how are you doing and how did you get started building in healthcare?
Thank you so much, Joe. It's great to be with you. And likewise, I'm so inspired by your founding journey and the heart that you bring to everything you do. I am also grateful to share more about building Boulder as we're serving patients with opioid use disorder on the backdrop of one of the worst public health crises of our lifetimes. But as you noted, it's been a remarkable growth story and being able to expand access to high quality treatment now to over 30,000 patients in 5 states.
That's incredible. And maybe to start, I'd love to, if you could take me back to, did you grow up dreaming of building or being like a healthcare startup founder? Or what were your dreams or aspirations as you were growing up?
I actually did dream of working in healthcare from a very young age. It was what I wrote my college application essay about. And I tried from many different vantage points to create systems level change in our healthcare system, so fueled by what can be done when you're successful in helping millions of people at their most vulnerable moments when they have access to good healthcare. And most people, unfortunately, don't. In my experience as a teenager, even with lots of resources and very supportive family members, I struggled to get care when I had a cancer diagnosis. And so from early on, I thought about all of the ways that we could improve our systems with public health impact. And I initially started working in DC, thinking that policy change is a very important way that we create kind of macro progress and innovation, and working on Medicaid demonstration projects, being part of the Affordable Care Act, being in DC as that sweeping reform was passed. It made me very excited about all of the change on the horizon. I also did a lot of work within Duke's health system and studying public policy while working in global health and in kind of Duke, North Carolina integrated system, where a lot of rural folks were trying to get access to good primary care and integrated behavioral health. I learned a lot about, again, the promise of direct care delivery, what it takes to be a clinician or in the support staff directly on the ground doing heroic work, and all of the systems and processes and technologies that could be really helping, but are often getting in the way. And so those experiences in kind of nonprofit healthcare work and in DC and health policy led me to my kind of third setting to look at healthcare innovation in the private sector, working as a venture capital investor, supporting startup entrepreneurs in many different industries and seeing how the speed of change and pace could be so much faster when you have a small, dedicated team of really talented, mission-driven people working together to solve a common problem.
Wow. And so if I'm remembering correctly, if I'm remembering correctly, you worked or helped during the Obama campaign. Is that right?
I was campaigning as a high school student, very excited about a progressive agenda that engaged young people, like a much more thoughtful way of getting people activated who wouldn't normally be part of the political system and thinking about the future. And then in working on the ACA, I also was so inspired, really in kind of bipartisan support for healthcare reforms, understanding that governments aren't the innovators who start the change, but are really instrumental to any type of healthcare innovation. So public-private partnerships and an appreciation from digital health founders about how government and regulatory frameworks influence their business plan, I think is essential. So some really good learnings came from those experiences.
That's really interesting. So you were working, you eventually worked in DC on some Medicaid reforms, and these were the early years. Was this after the ACA or like right around as the ACA was being implemented?
Yep, I was on the steps of the Capitol building when the ACA was passed, and remember those votes coming in and how excited everyone was because it had been decades since any type of healthcare reform had been passed. And I was also interning in DC at that time, working with a firm that supported Medicaid programs and the health systems who were trying to do advocacy and program based work with government funding. So exposed to a lot of different stakeholders that were relying on political support to move initiatives forward and thinking about reimbursement mechanisms because a lot of really fantastic and important healthcare innovation just didn't have a way to be funded under traditional payment models. So the ACA baked in a bunch of, at that point, pilot and demonstration projects for value-based care.
Wow, that's quite fascinating, actually, especially given today's the I'm curious to kind of get your take on the impact that the One Big Beautiful Bill will have, and but on your journey, what was your biggest takeaway from that experience, and how did it shape the next set of decisions that you made as you went into venture capital and eventually starting Boulder?
I think when I was in venture investing, again, just seeing the potential to create entirely new payment models, care delivery models, expanding access, not in the time horizon that you'd see in government, which is a group of 50 people over the course of 10 years, but for 100,000 people in 2 years. It was eye-opening to me how high the bar could be for taking what are great ideas on paper and policy and putting them into action. And I think so much, progress could be made if we had tighter partnerships again between the public and private sectors, leveraging very important guardrails and funding mechanisms from policy, but also the business acumen and execution required to pull off some of these things. So we saw it most recently in Oregon, where I now live and where Boulder is treating tens of thousands of people. The state tried to set up a hotline for people with opioid use disorder to call when they needed treatment, and they could choose between getting a ticket or citation for drug use or enrolling in a treatment program. And as with so many policies, it was well-intentioned. It was widely supported by the majority of the electorate in Oregon, and it failed because it's actually really hard to set up a hotline and instantly enroll patients in treatment. And at Boulder, as the state was trying so hard to operationalize this project, we were enrolling hundreds of people per day, answering every phone call, 99% phone answer rate, immediately texting patients who expressed interest in enrolling in care and getting them in same day. And all of that was possible through rapid iteration and building and technology, built with services models that we were, building as a startup. And I think because we had an agile, really interdisciplinary team and all of the principles that you see in startup building, we were able to do something that the government was not. So working together on initiatives like that, there's so much promise, but I think it's sadly untapped today because of how siloed those two worlds can be.
Right, and like as you were describing it, it's like um, the like in my mind, the government and working with government feels like the decision making process maybe doesn't feel quite clear. And so, as you're someone that's looking to build a startup, of all the risks that you take on, regulatory risk or just like I'm imagining longer sales cycles and like with your role with the in venture capital, I'm imagining you saw a bunch of these models and iterations around like how to move the needle on healthcare. On making healthcare better. What was the biggest takeaway during that experience that I'm imagining there's similar to digital health, or like you were really early in digital, like maybe that was like the digital health 1.0, like the initial iterations of digital health companies, and just curious, what were some of the things that you saw then that stuck with you?
You're right, kind of putting on the time machine goggles in 2012, 13, 14, when I was looking at healthcare companies. There was a lot of interest in introducing technology to traditionally like services heavy, pretty antiquated systems, and early discussions again stemming from ACA innovation, and how we can change reimbursement models to expand access, improve quality, reduce costs. We know in our country that we have some of the worst outcomes for the spend, and that there's a ton of opportunity to bridge that gap. And it was early innings. A lot of the new entrants in healthcare failed to appreciate the very complex payment kind of, cash flows. You could do a really phenomenal job taking care of patients, and it may not translate to payment if that person isn't paying out of pocket. They rely on their third party insurer or potentially an employer and multiple layers within that employer, and who's measuring risk and the outcomes that matter to them, the reporting that needs to be done, and the compliance considerations. Marketing and advertising in healthcare is also not always intuitive and changing all of the time. So there were a ton of learnings and a lot of brave entrepreneurs who were building during that time, figuring it out. And we stand on the shoulders of giants now and having much clearer guidance about how to work in a B2B2C system and appreciate some of the regulatory guidelines and the speed of scale that's possible to do safely in healthcare services. And now, as you kind of asked about my takeaway, I think there were so many learnings from that time in venture and seeing entrepreneurs. A key one was the importance of the leadership team, bringing together experts across all of these different domains, including a very strong clinical voice that guides all aspects of care delivery. So I consider myself a convener of the clinicians who are doing this work. It's why I started the company, working with visionary doctors, and the kind of business side of things, being close to the payers and understanding the mechanisms for building a business in healthcare services. And then, of course, the technologists who can help turn all that into a product that people use and love.
And so like going back to you leave the venture capital firm, did you already have the idea for Boulder and you were leaving to build Boulder, or did you just, you wanted to build and help solve problems within healthcare, but you kind of needed to find an idea or the right idea or problem to focus on?
I never thought I would start a company. And the more incredible CEOs and founders I met, the more I was certain that I had no business starting a company. But it was a mission that came about as really a calling and seeing the problems that I was able to see firsthand in my seat as I was immersed in the addiction treatment sector. So one of our portfolio companies was a platform of outpatient clinics. And in the years 2014 and 15, when the opioid crisis was starting to become front page news every day, I was in these clinics in rural New England, seeing firsthand exactly what was happening, contributing to the crisis and the solutions that were so promising. People getting better, accessing medications and peer support, and coming back to see providers looking like entirely different people, because when you heal from addiction, it really is transformational. So I was so moved by this and asked a lot of questions about why we weren't seeing proven treatment everywhere, and finding all of the structural barriers that were in place. People were taking their kids to addiction treatment centers because they couldn't get childcare, and there were people selling drugs in the parking lot. We had folks who didn't have driver's licenses and had really busy work schedules and late shifts and weren't able to come in for their visits and had to choose between their job and their medicine. So telehealth became a really obvious solution, but at the time it was not being done at all in addiction. It was actually illegal to have the kind of prescriptions for addiction medicine without an in-person visit. So what we had to do was build a company that helped create a care delivery model that was safe and effective in a virtual environment, and a payment model that rewarded good outcomes and made this affordable for patients who were low income, and policy change through advocacy for what works so that we could scale it.
Wow. So one of your portfolio companies had these outpatient clinics in rural New England, and you'd visit. I guess the thing as you were describing that was going through my mind is just how the it's far easier for folks to like see that and then say this is sad and really painful, but it's like engaging is like I was trying to put myself in your shoes, and it was far easy. I mean, imagine it would have been far easier for you to just say this is very sad and continue your path, investing and hoping that the outpatient clinics. You're basically solving, like, in my mind, one of the most difficult problems within healthcare. And the model also was, it wasn't legal to deliver treatment over telehealth at the time. Like, what was going through your mind that this is a problem you had to dedicate the next decade of your life solving for? And why not do anything else, just given how difficult, at least I'm imagining it was to just get started?
I have to chuckle at your saying this has to be one of the hardest problems in healthcare because it felt that way at the time, but little did I know how hard it actually is. And every year there's a new existential crisis that also represents an opportunity for transformational change, whether it's policy change or pains of scaling. We're trying to do impossible work, and you are too. We're trying to take a system that's massive and slow to change, and $1 trillion as an industry, and as small startup innovators make a meaningful impact. So it's not easy, but when I met with many of the patients at these clinics and heard their stories and started talking about potential solutions, what if you had an app where you could get care at home and you wouldn't need to miss work or, bring your toddler to this clinic on the worst part of the town because no one wants an addiction center in their backyard? What if, why do we have to take all of these urine drug tests? It feels like most of the valuable time patients are here with their providers after taking 2 buses to get here is spent just taking a urine test and answering the same questions over and over that they could just do asynchronously. The more questions I asked and heard patients validate that this was not the treatment experience they wanted and it could be so much better, the more fuel that was to then question the system and reimagine it. And when the doctors and the peer recovery specialists and other support staff at the clinic started also weighing in and saying, yeah, this would actually wildly improve my experience too, it was just the greatest motivation. Uh, you hear so much in healthcare about problems that can't be solved. And that's all I was hearing about addiction. People just don't want treatment. There's never going to be enough addiction providers. You have to hit rock bottom before you can get any help. And when the experts, the patients who had this condition, the doctors who were some of the pioneers in treating it, said that's not true, this model kind of created itself. And I feel like carrying it forward is such an amazing opportunity. It's really a privilege. And it's hard to imagine doing anything else once you've started measuring outcomes in terms of people regaining custody of their children, avoided overdose deaths. Those metrics are so important. And to be able to build a business and make those your KPIs, pretty unparalleled.
Wow. And so it sounds like it was really the patients. It almost sounds like you were called to do this. Walk me through. So you decide to do this. How do you go 0 to 1? Like, some of the things that I struggled with were, something as simple as, hiring, like, you non-physician cannot hire physicians. And for me, at least, it was like, I left my last year of school to start. My healthcare experience was non-existent. But for you decide to do this. I'm imagining you have some context, given the investing you've done in healthcare companies. But what were some, like, the earliest things that you did once you decided that this was an interesting problem for you to solve? Did you leave the VC firm? And just curious to kind of get a glimpse into those early days.
Yeah, I think building teams of people who are experts in the things that we talked about earlier, the care delivery, the technology, and in the business kind of context is so important. And you don't have to have all of those. So what you have, Joe, is humility, curiosity, and a great way of kind of bringing people along and telling them the story that inspires action. And I think that's what all healthcare entrepreneurs probably aspire to do. So being surrounded by some of the greatest talent in those domains got made 0 to 1 in a very hard business much easier. And my co-founder, who is focused on the technology, was able to help us take a lot of audiences, patients who are not used to using apps and may have challenges with Wi-Fi and data, providers who use really clunky EMR systems and the EMRs don't actually correspond to the way they want to deliver care and the outcomes that they care about in tracking patient progress, and payers who needed to see actuarial data and claims in a unique way in order for us to change the payment model while working within their existing systems. So there were lots of audiences to build for and considerations that my co-founder Dave was able to help us hone in on. And then really critically, visionary addiction doctors and being able to work with some of the best in the field who are still with us today, Dr. Steve Martin, Dr. Andy Mendenhall, Dr. Amanda Wilson, people who were treating addiction like a disease while the rest of the country was treating it like a moral failure. And we're prescribing medications that are still underutilized, but back when we started Boulder, were very rare and very difficult to offer patients. And to be able to bring their insights into a product and care delivery model helped us form the foundation for Boulder, and now has led the industry so much further in how we deliver evidence-based care. So all credit to the experts who were able to help build our early clinical model, and to our investors who recognized that building the clinical model and focusing on outcomes was, rather than seeking revenue first and then trying to build a model that fit within the existing reimbursement structure. If we had just gone after patients who were able to pay out of pocket and were more affluent, or we had gone after payers for the typical fee-for-service reimbursement model for volume, we wouldn't build the same thing we did. And that is where innovation can really be born.
Wow. All of those things just sound like, I think you make it sound simple, but I'm imagining even getting your co-founders on board, it might have been, maybe it was straightforward, but I'm curious. So you decide to do this. Did you already have your co-founders, or like, what was the sequence of events to get you have this story and this problem that you're extremely passionate about. It sounds like the visionary doctors had like inspired you, and for you to see a way to, and also the patients, that you saw a way to a care delivery model that could substantially improve how we cared for addiction or treated addiction. What then? Like, what was the first thing that you did? Did you quit your job? And I just curious to kind of get a glimpse into the Stephanie that was, had this dream and was starting out.
I think as a first-time founder, you've got to make so many mistakes, and you just hope that they're mistakes that you can recover and learn from, and not, fatal errors. And luckily, that is the course of the Boulder journey. Learned a lot in the early days, including how to focus relentlessly in kind of those first few steps. So having a big vision, which today still the vision is for an entirely different healthcare experience for patients and providers, to become the most trusted name in addiction medicine. But breaking that down into a year one roadmap with limited funding and very few people required skill sets that complement mine, including our product leader, who was actually introduced to us by First Round, our shared investor. And when Josh Koppelman brought Dave into our founding team, it really changed the way we thought about structuring our roadmap and setting discrete milestones that we could hit in order to get to that next level of funding. So always a proponent of focus and ensuring that you have your early stage vision that is inspiring and big, and it may be big enough, or you may actually expand it as you grow and learn. But focus is so key, and it's easy to kind of underestimate how much it's going to take when there are so many surprises around every corner in healthcare. We're still today innovating and learning as we go and finding wrinkles in our plan. Every state is a little bit different. The regulations and the culture are different. Working with Medicaid is different than working with a commercial plan. And so the more we gain confidence over things like payer contracting and, patient enrollment, we're always humbled by new learnings as we scale. So baking those into your plan and making sure you can be successful and learn quickly from those mistakes is always key.
So like when you raised from round, was that the very first round that you no pun intended, that you did raise?
That was, yes. First Round led our seed with a number of other phenomenal investors in 2018, a very different time for all of us.
Yeah. And what was the time from starting to raising your seed?
I have become obsessed really with the addiction treatment sector. Coming out of investing and looking at so many different treatment models, I spent time in different outpatient clinics, in the community, working with peer groups, going to AA meetings. So a ton of whiteboarding and research and direct conversations. And then when it was time to get started, I think we raised capital knowing we needed some found in order to sell to health plans, and defining those milestones in a way that felt right for the company, which was really proof of concept on the care. A lot of milestones are financial, and at Series A, we did have more of a revenue, driven story. But at Seed, it was about proving that people would use a virtual addiction treatment, that it was safe, and that payers believed in it, and that we could get a reimbursement model or contract that was different from status quo in order to build for all of the things that wouldn't be reimbursed under the traditional system, peers, case management for social supports, and the technology itself being able to deliver care through text messaging and other pretty innovative ways of serving patients. So that was step one. And first round was an early believer in our ability to do that and unlock a new market that didn't exist yet.
And remind me, how much did you raise in your seed?
About 3.7 million in 2018.
So you raised a few million. What then? What's next for you? And at that time, so Josh introduced you to your CTO and co-founder. Who was on the team as you raised from first round? And then it sounds like you were at the time breaking down the milestones you needed to get to the next round. I'm remembering when I went to YC first, and the raise our pre-seed after, and um the biggest challenge for me, at least, was figuring out was always the sequencing of things, and I felt like I never had enough time or money to do everything that I needed to do. And you mentioned focus early on and choosing like what are the things that have to be done now, and to then enable me to stay in the game long enough to figure out the things that are the other things. But curious, what was what was the team like as you raised the seed, and what did you need to do, or did you focus on proving right after towards your next round?
Never having enough resources or money resonates tremendously. And looking back, we were comically scrappy. With a few $1,000,000 in a space like ours, you could easily spend that all on legal. And, it was trying to kind of cobble together in a very grassroots way the leadership we needed from top clinicians, the kind of rigor around data and outcomes that we could show even in Google Sheets as we were documenting our patient encounters there, and an anchor partnership with a like-minded payer that saw the talent on our team and wanted to build with us rather than look at 2 years of track record before doing a contract. And we were so fortunate to have all of those things come together for us. Our first customer, a Blue Cross plan in the Pacific Northwest, our champion there, helped us really have a contract prior to seeing our first patient, just in the track record of our care team and our vision for how we could be driving outcomes for them and held accountable for those outcomes and the way we were paid. So our Series A came in 2019 after bringing that kind of contract ready to execute, a plan for the care model that had been vetted with pilot partners and an FQHC that was so kind and willing to work with us on patient engagement so that we could test and learn about how to build an app. The kind of proof of concept on the services model, it was just enough, as you said, to stay in the game and then invest in more sophistication at the Series A.
What was the biggest, as you think back to that time during the seed, and you get this amazing Blue Cross plan that was an innovator and maybe visionary to see um, what the future could be together. What are some of the biggest learnings during that period, going from your seed to the Series A, that knowing what you now know, you wish you could go back and potentially change?
I think uh, the thing we could never have predicted, but that changed everything for us, was raising our Series A in December of 2019, not knowing what was around the corner in the first quarter of 2020. So a lot of our focus was being able to operate a telehealth company in an environment where no one really believed in the potential of telehealth except the people who were closest to the patients who were struggling with addiction. Payers were skeptical because there was no regulatory pathway yet for all virtual care and not a lot of payment mechanisms for it as a result. Providers of major health systems said, I really need to see my patients in person. I don't see how you're going to be able to establish a great relationship with someone virtually. And can you even trust people with addiction to have that type of flexibility? there was stigma and skepticism and just a sense that this was maybe a 10-year time horizon, not imminent. And so when, with the stroke of a pen in 2020, the federal government said all visits can be done virtually and we should be expanding access to addiction as a matter of public emergency, everything changed. And now there's been widespread adoption and proof not only that telehealth is safe and effective, it's actually better than in-person care on a host of metrics, including patient retention and engagement. So we couldn't have predicted that, but it certainly would have changed the shape of our journey in those early years. And we were really grateful to be ahead of the curve and being able to actually act as some of the very first providers for patients who were in crisis. When their pharmacies or clinics closed during COVID, we had capacity and were able to start seeing patients right away.
Wow, because the pandemic, December 2019, 3 months or 4 months later, the world is shut down. Uh, what was that like? What was going through your head? In one case, like it accelerated the telehealth trend. So now, I think you mentioned what you thought would take 10 years to be is there overnight. And on the other end, the pandemic, imagining impacts how you previously worked, and you might be thinking of like how to conserve cash while you have all of this volume. What was that period like, and what were some of the key decisions that you made?
There was just widespread uncertainty and chaos, from all of us wondering if we were going to get sick and be okay to then asking if there was going to be a nuclear winter and venture funding and the markets were going to shut down, and suddenly they were taking off. I mean, it was just so many ups and downs, and we can all look back on it now and kind of forget what it was like in those moments. And it was so foundational to Boulder culture that we grew up during that time, where everyone was sort of forced to respond rapidly with the best intentions and so much heart to like run to the crisis and help with whatever resources we had. We hired our now chief operating officer during that year, and it was the first year we started seeing patients, and she's still with us today. And we look at the arc of this journey, being called to help people in Oregon and Washington, where they were first to get the COVID cases in the US, and all of the methadone clinics were shut down. People were going into withdrawal because they couldn't get their medication. Pharmacies were shut down, so people couldn't pick things up. Emergency rooms and hospitals were saying, please keep people out and treat them at home if we can. We had patients who were calling us from being sheltered in place, and their families didn't know that they were using drugs and they were desperate for private help. We had people who lost their homes and all of their belongings in wildfires that were sweeping through the Pacific Northwest on top of everything else. And in those moments, we were, again, documenting in spreadsheets. We had peers who were answering patients who were reaching out to us on Facebook. We had no enrollment team. We expected to really have like a very small subset of patients with one payer in one state. So that's what we had staffed for. That's what we had funded. And instead, we were some of the first kind of frontline people to solve this massive public health crisis. And the team really rallied around it. And today, there are so many aspects of our culture, I think, that stem from that. There's the advocacy that is so key to what we do. We're constantly thinking about systems level change and how fast things can happen when policies move, for good or bad. We're also very scrappy and resourceful. And, we know there are things that we want on the roadmap, but if we don't have them today, a lot can be done with just a kind person on the other end of a phone talking to someone who's going through a crisis. And we just remember that we can do really hard things. And in the face of uncertainty, which is par for the course in startups, whether there will be funding or not, whether we'll be able to get the contract closed, at the end of the day, if we can look at all of this uncertainty with curiosity about how we can innovate and help, that's really what drives our team.
And so you raised a December 2019. What were the milestones that maybe at the time you thought you needed to hit to raise your B? The world shuts down. What are the new milestones or like focus areas that you needed to hit to then raise your B? During that period of time, what were the biggest takeaways for you?
Every company's a little bit different on milestones. And for us, wanting to do a new care delivery model with value-based payment, we thought it was very important to execute on our payer outcomes and show that we can build a care model around an alternative payment model, initially with one payer, and show success there. And again, we thought it was going to be one market, one payer, and ended up being the entire Pacific Northwest with then patients calling us from all different health plans, and our mission being fulfilled by saying we'll take all comers, regardless of insurance carrier ability to pay. That led to an interim financing round because we had a ton of demand and an opportunity to prove the care model. And so there was a bet we were taking on being able to provide care without billing initially, but knowing that if we had patients with good outcomes that we could then go to a plan and, as an unproven provider in a new space, say, we're seeing some of your members today, they're doing great, let's look at the data together and talk about a contract. So much of that kind of seed to A was proving out the care model, building relationships with payers, but still very early on revenue. So then as we looked to the next round, the financial picture started to become more important, and we were able to show contracting progress in line with the thesis I just shared with dozens of plans, some under fee-for-service initially, others under more value-based arrangements, and then over time moving from fee-for-service to value as we established some of these milestones. So I think go-to-market was kind of early, and the playbook getting developed over this first few years has informed later stages. So we can kind of take this state by state with a similar approach.
What was the biggest challenge during that time? I'm imagining like there's probably many fires that have to be put out. But what was the biggest challenge that kept you up? Kept you up most during that period?
We now sort of take it for granted, but it was remarkable in that first year that we saw great outcomes, stellar retention, sky high patient satisfaction, and that has persisted. So what a great discovery that telehealth for addiction medicine, then unproven, works and works incredibly well across many different geographies and patient types and levels of acuity. What was really challenging, I think, was the kind of setting up revenue cycle management and payer contracting for the first time. That's still hard, but it was, I think, harder than in Medicaid for telehealth companies, where often we were approaching the largest payers in the country and they said, you're the first provider that we've ever done a contract with that's all virtual. And the complexities were numerous and not the obvious things. They agreed that the care model was great and that it was worth paying for, and but there wasn't a way to put this bespoke payment agreement through their billing systems, or the compliance pathway didn't exist to certify an all telehealth provider because they required an in-office inspection. So there were a series of things that we had to tackle in those early days. And as the industry has advanced, so have we. So it's becoming much easier now, but certainly at the time, we're pioneering a lot of new pathways for telehealth.
The thing that I find fascinating about your journey and about you is you speak about this, like, at least to me, because we sell to small businesses and haven't had to sell to payers. Our sales cycle is a month on average. So I'm addicted to like quick like feedback and selling to these very large payers, especially for Meta. It just feels like to me, like it's like waking up and getting punched in the face, and like for you to learn whether it's like um but you approach it with like such thoughtfulness and such calm. Why, like when you started out, you mentioned like one of the things that you needed to prove out was this alternative payment model. So you got the first payer, the Blue Cross plan, I believe in the Pacific Northwest. Was it in Oregon?
Premier Blue Cross. So they are Washington, Oregon, and national in employer scope like Amazon and Microsoft.
Amazing. So you get the first one. I guess, how did you get the first one? And then as you went from that first one to others, how did you build out this like enterprise, almost like Uber enterprise, like sales model that gets you the plan? And then you still have to engage the patients. So it's like it's like extremely difficult things that you have to get right for your business to work, but that you sequenced and eventually did. How did you get that first one? And then how did you make it repeatable to get the subsequent?
Well, you're very kind, Joe. I think patience is so necessary in this industry, and happiness is just kind of aligning expectations with reality. So assuming that a payer sales cycle is going to be quick is a recipe for disaster. But happily, the sales cycles have accelerated as we've partnered with plans and established a playbook, not only for how we communicate the value of Boulder Care and the number of patients we've treated that create a very proven track record, but also in how we've met payers where they are and understand more deeply what constraints they face in these massive organizations that are very risk averse by design. And that has helped us establish relationships with a handful of health plans that are national and being able to leverage the relationships that they have internally, that vouch for us being a trusted provider that delivers on the things we say we will. And so that integrity is helping us grow further faster, as well as members of our team who are tasked with partner success and with value-based contracting. So as the industry is changing and there's a lot of pressures being placed on health plans, we know that there are some plans who are cutting rates and concerned about, the challenges of new work requirements, administrative issues that are going to cause enrollment churn. Because we have such a great partner success team that meets so regularly with our plans, we can not only report on the things that they care about in terms of member engagement and success with Boulder Care, we can also ask what challenges they're facing more broadly and see where we can help be part of their strategy. We're talking with patients thousands of times per day, and they struggle to often engage with members at all with the very limited tools they have, like direct mail to the wrong address or incomplete phone numbers. So it's been very helpful over the last 6 months as patients are asking, what's happening with Medicaid benefits? Am I going to lose my provider? We can reassure them and give them the information the health plans want us to convey about how to update their contact information and be ready to meet new requirements. So just finding ways, as you would with any customer relationship, to deepen the partnership and solve their problems, but recognizing there are constraints in how quickly they can move and where we have complementary skills that work toward common goals.
Yeah. How long did it take you? Like, what is your typical, or the typical payer sales cycle? And like for that first one, did you hire someone that was focused on payer sales, or how did you get them?
Yeah, the founder driven sales motion was, most of our early innings, and I still stay close to that process and being able to tell the Boulder story and understand what payers are worried about so that we can guide the business toward those things. But we have a phenomenal team, including our growth partnerships leader, Mariana. I think the sales cycle is so varied. One thing that has become much easier and quicker for us and probably across the board in telehealth is getting in network with health plans is now a more straightforward process and can be done in 60 to 90 days. Getting some level of reimbursement and starting a track record and actuarial claims can be helpful for some plans that want to see those results before taking on the investment of an alternative payment model. And for other plans, we're able to kind of go directly with an alternative payment arrangement with the benefit of having worked with that plan in other states and knowing their teams and kind of contracting process to streamline it for them. But even still, a sales cycle could be 8 months or it could be 2 years, depending on the complexity of the payment mechanisms. And we want to get that right. Having the right metrics for performance payment is really key for both sides of the provider and the payer. So as we are building better infrastructure and AI is helping us get data much more rapidly to our plans, I think there are certainly opportunities to speed that up and make it easier for payers to recognize the value that they're getting from value-based care.
And so pivoting a bit to today, I think in the 0 to 1 phase, it seems to me like a lot of it is just trying to get something off the ground and figuring out, whether your initial thesis works out. But as you were speaking, some of the things that stood out to me is of the few bets that you made that maybe differed from other addiction treatment vendors. It seems like you bet heavily on serving the Medicaid population. One, I'm curious to hear why, or whether it was like an actual bet or just like it seemed obvious at the time. But and also curious, like, how did you think about, like, as new vendors popped up and you raise a ton of money, how did you stay true to the things that you believed were the right way, or the best way to build versus, the noise that maybe, you
Phenomenal questions, Joe. Could do an entirely new podcast session on just core values and how to maintain culture and make decisions, but I'll take that one first. I think, again, being stress tested in early days on what matters most and forced to pick a North Star. We say patients come first, and every telehealth, every healthcare organization says that, but we really want it to be radically true at Boulder Care. So in times where we face, risk from regulatory pressures or demands from the investor market or, other factors that are stakeholders we care a lot about, but can't come first in that moment, It's really about patients. And so that guides so much of what we do. And then our job is just to share with other stakeholders, our payer customers, our investors, our provider teams, why we all win when patients get well. I think the importance of operationalizing core values is something we also think a lot about as we're scaling. It's easy to model that type of behavior when you're a team of 10 or 50, but now that we're approaching 250, we have to kind of educate everyone who joins the company about what it means to be mission and values aligned. So that is a job. And communication, culture, hiring, onboarding, all of those things need to be kind of structured and implemented in a way that can scale. We call it bottling up the Boulder magic so that we can spread it. And the other aspects, I think, of falling into the pitfalls, I guess, that others fall into that we haven't. We have seen so many ups and downs in the venture market, for example. We raised money before telemedicine had its boom. And then we were faced with the pressures of growing as quickly as some of the other telemedicine companies as competition was starting to displace the slower kind of incumbents. And we saw that rise and fall. We saw that providers who weren't putting quality first or thinking about the long-term payment dynamics, had a hard fall. Kind of stability and keeping focused on what matters, patient outcomes, quality, compliance has really helped us withstand all of those storms and will continue to into the future. We talk a lot about building slow to go fast. So setting the right foundation, having the right quality assurance, the right payer partnerships so that you can then scale, to tens of thousands of patients in 5 states without some of those risks. That has been, I think, a really important part of our journey, and one that I hope other healthcare founders will take forward, and just building thoughtfully, but still at the speed and urgency required for some of these health conditions.
Yeah. And was focusing on the Medicaid population a conscious decision? That was somewhat of a like you other vendors went here and you intentionally chose to do the harder thing first.
We did. That was intentional, knowing that the majority of patients with substance use disorder are covered by Medicaid, and knowing that in value-based contracting, that's the place we have the greatest opportunity to make an impact and move the needle. So there's a small subset of people with addictive disease who can afford to pay a few $100s a month out of pocket. They're not the ones who are the most kind of sick and underserved. And the folks who are covered by Medicaid or uninsured or underinsured. And when we help a patient that is costing the healthcare system $50,000 a year, we only need to spend a fraction of that. And that is how we really move the needle in healthcare. So it was exciting to me in being able to help people who needed it most, and in the economic opportunity of tackling the real problem. At a time when we know that there's so much focused on healthcare efficiency and cost cutting. There are hard things about that, and then there are easy things. And when there's $1 trillion spent on waste, when we're spending $30,000 to send someone to rehab when they actually aren't getting better in that care setting for addiction, these are places that are really exciting for founders disrupting the industry.
And last one on this thread, with AI today, it somewhat felt um, it's felt very similar to the pandemic telehealth boom. And I what were and especially with there are a few vendors or other startups who were like raise a ton of money alongside Boulder, but Boulder always struck me that you mentioned these core values and operationalizing them so that you are radically patient first. What were some of the other decisions that you made that that like maybe differed, like strategically differed from what other vendors or companies were doing at the time that ended up being right? And maybe on the flip side, like what did decisions did they make that you wish you had made that because that you later had to course correct?
Great questions. I agree that there's a ton flooding into AI right now, and a lot of it's really valuable. Some may end up being commoditized. My thesis, if I can pretend to be an investor again, is that the companies that are applying AI to solve these really complex problems in healthcare that own the services delivery and the relationships with payers where the real dollars are will be the winners, and some of the vendors may fall away over time. So we're focused on applying AI to very specific parts of our model where we can drive leverage. And I think these are areas that we're investing in now with the, again, intentionality. We don't need to start by replacing people who are doing great services. There's a lot of inefficiency in billing, credentialing, revenue cycle management, staffing and triaging. There are so many problems that we're solving with AI that haven't reduced any jobs. In fact, actually make people, I think, more likely to engage and stay retained in a otherwise really complex business because they're taking some of that administrative stuff off their plates and focusing on care delivery. Um, so your question was about
Like similar to with going back to sorry.
the retrospective on what we would have done differently.
Right. Are there specific things where you did do and you're like, this was a contrarian bet at the time that other competitors or vendors in the market like didn't see the world this way, and that was ultimately good for us? And then were there others on the flip side that you wish you'd done differently?
I'll start with the pat ourselves on the back question. And I think illustrative of being radically patient first was in 2023, the DEA, which oversees a lot of the controlled substance prescribing we do as addiction medicine providers, put out a draft rule that would have threatened to take care away from some of the most underserved patients by requiring in-person visits. And I had conversations with a lot of other CEOs and industry over the weeks following, and discovered that their response was to raise alarm bells. They didn't want patients to be concerned and go find other providers. They didn't want investors necessarily to know that this was a big threat to their businesses. They wanted to see if it would blow over. And we took the exact opposite approach at Boulder Care. The first thing we do always is think about our patients and what they need. So we reached out. We got this news on a Friday. Over the weekend, we were working to get messages to all of our patients and ask what we can do to support you. If this rule comes to be, do you have a primary care provider nearby? Do you have access to transportation? And then we assured them that no matter what, we would make sure that they were covered and taken care of. We then launched an advocacy campaign that resulted in over 40,000 public comments protesting largely the DEA rule and ultimately reversing it. And this advocacy is another core value of Boulders. We aren't just advocating for our business or even the patients we treat, but for the entire industry more broadly so that we can solve these societal problems. And so I'm really proud of the way the team mobilized to jump into action in that moment and how it did differ from other providers, but ultimately it helped us all win. Where we've made missteps or where we wish we had done things differently, I think in some of the early years, we were focused so much on trying to drive efficiency when we needed to get to path to profitability, and the industry was moving more toward fundraising based on profitability metrics. We were trying to solve problems in the same way that other providers were trying to solve them. So we have a lot of no-shows, we have capacity challenges, and we need to bring up utilization. We were thinking about all of these problems for many, many months. And it was only under the kind of resource constraints of saying, like, we have to solve this problem in a way that's uniquely Boulder and we don't have a lot of money to do it. Again, that scrappiness, that we divined what's now one of our greatest innovations, on-demand care. So being able to now see patients in the urgent moment of readiness by having a queue where they can wait and see the first available provider has been a game changer for our patients and a model that we're really proud of. But being able to do that sooner would have obviously helped us save a lot of cycles on trying to solve a problem that was just structurally not going to be solved under traditional scheduled visits. So great outcome, but a tough journey to get there.
I appreciate your honesty. I think and maybe as a quick follow-up to that, in the example you gave with the potential changes with the DEA, you chose to be radically transparent and you prioritize the patient and also share like the potential impact with all stakeholders. And it's even with the One Big Beautiful Bill recently, it struck me that you choose to engage. Early in the conversation, you mentioned you're very bullish on private-public partnerships. I guess when I hear of these changes, like the One Big Beautiful Bill, part of me just feels like this is all the things that I have to deal with. This is just like I feel helpless sometimes and just say, I'd prefer to, just focus elsewhere, but you choose to engage, which I think is so important and so inspiring, and something that, from in the time I've known you is just like, I find myself wanting to do more because of your example. But why choose to engage, and what's the vision potentially of the regulatory path forward for addiction treatment, but also just broadly virtual care?
I think there's just so many examples that I've been able to see over the years at Boulder of against all odds, the kind of smaller innovator or the small group of civic minded people being able to create change. And that's what inspired me when I was a teenager to go to DC. It's this, notion that the people are the ones who should be setting policy, and that right now the opioid crisis is one of the most pressing issues that families and communities are facing. Many of the people who are struggling with opioid use disorder on Medicaid are in deeply red states and counties and have elected officials who are tasked with passing this legislation, implementing some of the changes that we know need to be made. And so putting the right amount of pressure on those elected representatives and raising awareness among the people who are going to be hurt by this legislation is a very challenging task, but one I think that is so worthwhile when we think about the tremendous ROI on the kind of Medicaid program. It's 60 years old and has, in one generation, really transformed the safety net, and that is fragile. So it really feels like a matter of awareness in lots of ways when the most painful part of these cuts don't really hit people until late 2026. We have a midterm election before then. A lot of work can be done between now and midterms to change the shape of this policy and protect people on Medicaid and protect people with substance use disorders. So there are certain parts of the legislation that will impact our business, and it'll be kind of devil in the details on work requirements, whether people with SUD are going to be exempt from those, and the way that we make sure that people who should be eligible stay on the rolls and don't fall off because of administrative issues. I think we can play a big role in that as providers who engage patients and as private sector companies who hold a lot of really promising data about how we can drive efficiency in care, eliminate fraud and waste and abuse and all the things that we hear, but in practice in a way that doesn't involve taking people's benefits away or creating even more waste and expense by trying to administer new rules.
And with the like, how optimistic are you that um the things will change?
Well, Joe, you asked how I started solving some of the hardest problems in healthcare, and it's by being blindly optimistic to a fault sometimes. But I have to believe that we will kind of rally to protect people who do rely on these safety net programs. But it is, a truly challenging time. It's creating uncertainty and harm, just the notion of what could be coming in the coming, months and years. We certainly are feeling it and talking with our Medicaid partners who are experiencing layoffs and trying to understand how to communicate both internally and with their members when there is so much uncertainty and complexity. So there's a lot of work to do, but the antidote, I think, to anxiety is action in the places where we can influence policy or just make life a little bit easier for the person in front of us, whether that's the patient or their family member or one of our payers, in being able to solve problems for them. There are helpers and healers in every aspect of healthcare that we work in on the business side and in providing direct care. So any way that we can empower them as we get to this next phase and learn more about the kind of policy in action. That's what we're focused on right now. And I think in kind of broader advocacy, I can also share the coalition that we've started to build, Majority for Medicaid, which is a very bipartisan group of healthcare operators across different industries serving Medicaid patients, and some of the work that we're doing to help shape policy in ways that achieve efficiency goals and also protect patients who need care.
That's amazing. Stephanie, thank you so much for coming on. This has been incredible. I'm learning so much. Few quick rapid fire questions where I selfishly just ask for advice. So, if you were speaking to someone, a computer engineer that is dropping out of their last year of school to build some sort of healthcare company, what advice would you give them given all of the things that you've learned as a founder yourself and as a healthcare investor?
Say that are looking for work that's meaningful and purpose driven. There's so much opportunity in healthcare to spend the majority of your time that you spend working doing something that really matters in people's lives. So that type of fulfillment, as well as creative challenges and solving big problems with measurable impact, makes healthcare an amazing field to go into right now.
And then two, if you're giving advice to a company with about 60 people, like Vitable, given that you're now at 250, what are the things that you wish you knew at 60 people that were really important to helping you, or what are some of the things that helped you get to 250 and maintain the core values, and maybe what are some of the things that you wish you knew?
I think that as a founder with a lot of kind of bias for creativity and trying new things, innovating quickly, I didn't appreciate the importance of structure and process as much as I now do. So I've become a convert to the right amount of process so that you have things documented, for example. You don't have a single point of failure when someone who's been with the company since day one isn't there and no one knows what the passwords are or why we do things the way we do them. So more intention around communication and teamwork is really important as you start to scale. If you don't give people clear directions on that, they're going to bring whatever experience they have as a frame of reference from their past workplaces. So also make sure that you're hiring people who have experience you want brought into. I think interviewing, hiring, and onboarding become incredibly important. So learning really quickly during that process about how to educate on the kind of operating rhythms of the company and the core values. There's, I think, a lot of benefit to just every year revisiting the values with the benefit of employee feedback. Who is embodying these values at the organization? How have you seen these happen in practice? Are these still the things that we live by? And doing that with enough anonymity that it doesn't feel like the values were just written by the founder and are kind of outdated, but actually represent the things that employees see and feel every day.
Fascinating. Last one, I'll just double click on the values piece. I guess um, if they change every year, like one of the things that you said early on was that these core values have helped you make these decisions. How often do they change, or is it mostly like taking stock is the exercise of taking stock is more important than the actual than any change that may or may not come from that exercise?
Nailed it. I think taking stock and interpreting the values. So while the values for us have been enduring principles, we think about them the way you would the Constitution. The context has changed, the business goals and the people have changed. What do we mean when we say patients come first? Or one of our core values is around instilling empathy to change hearts and using facts to change minds. The literal interpretation of that is one thing, but how do we use data to tell stories? How do we make sure that patients are front and center in thinking about how we eliminate stigma in our industry? So I think taking stock and really letting people weigh in on how they interpret the values, making sure that everybody has a shared agreement of what that means. We just launched a survey recently asking about culture at Boulder and how people would define it. And when we interview, being able to say, this is how employees define culture, not just me as the founder who thinks it's the most beautiful company imaginable, but a shared definition. And even putting that into the performance review process where people are recognized for exhibiting core values and it's part of their compensation and, review format.
And I suppose, like, how do you build consistent culture across all of these different disciplines? I think any digital health company has like this aggregation of clinicians, like sales folks, engineers, and it's like this aggregation of these like interesting disciplines, and that can be quite different. How do you build a cohesive culture across everyone? You also in making room for like the maybe eccentricities for like how eccentric each group can be.
Exactly. Well, when you're at 50, 60 people, as the founder, you're influencing so much of the day to day. And you're seeing how your leaders are embodying the culture and values and hearing firsthand from you and what that means. As the company gets bigger, especially in a distributed team, it's moving quickly, you really need to empower leaders and scale from the middle. So not just the executive team that you're spending your time with, which is very important, but the people who are then their number two, so that you have much more like cascading information. People are armed with enough of the business language and kind of core objectives that they can guide their teams, but not so much that they're bogged down and working on the business when they need to be in it. So finding that balance is a challenge, but it's such a worthwhile one. And we certainly want people to have their own interpretation of, their norms and maybe their traditions. Our engineering team is always delighting us with some new thing that they've done or a volunteer mission that they have gone on during their on-site. A lot of creative games that Dungeons and Dragons. There's all kinds of fun things happening on the product side of the house. Very distinct from our revenue cycle team. That is wonderful to have that type of eclectic or diverse workforce. But what I'm always really mindful of is shared vision and values so that when we do need to move really quickly around a goal, everyone is speaking that same language and understand, the eliminating some of the acronyms or the financial metrics. What does Series A actually mean if you're a peer recovery specialist? So I'm very mindful of that. And I think it's, again, challenging but worthwhile. And also having a very united front between kind of the business and the clinical sides of the house. And in all areas of healthcare, we see examples of what goes wrong when there's a perception that the suits are making the decisions for the caregivers and not empathizing with their experience and what they need. So we try to keep the provider experience front and center and our clinical leadership's voices at the table for every important decision.
This has been amazing. Stephanie, thank you. Your wisdom, hard earned wisdom is quite refreshing, especially coupled with the humility that you shared.